If your doctor recently told you that getting your blood pressure down to 120/80 was a success, I need you to stop and read what I am about to share very carefully. Because a major study tracking more than 15,000 older adults for 5 years found something that directly contradicts what most doctors are still telling their patients today. And the gap between what this research shows and what is actually happening in medical offices across the country is, in my view, one of the most urgent and underreported health issues affecting people over 70 right now. Here is what the study found. The older adults with so-called perfect blood pressure, the ones who hit that textbook target of below 120, had a 28% higher risk of serious falls requiring hospitalization. Their mortality rates were actually worse than the people whose numbers were moderately higher. The group with the longest survival and the best quality of life was not the group with the lowest numbers. It was the group in the middle. I'm going to explain exactly what that means for you, why it happens, and what you should be doing about it starting today. By the time you finish reading this, you will know the actual blood pressure range that research links to the longest survival in older adults, why the standard target that most doctors are still using may be genuinely dangerous after age 75, and a simple 3-minute test you can do at home tonight that could prevent a life-changing fall. My name is Dr. William Madison. I have been in clinical practice for more than 20 years. And what I am sharing today is not an opinion or a fringe view. It is based on research published in some of the most respected medical journals in the world. Research that most patients have never heard about, and that has not yet changed the way many doctors practice. Let me paint a picture that I want you to recognize. A 78-year-old patient walks into a doctor's office for a routine checkup. Blood pressure reads 145/86. The doctor opens the standard guidelines on their computer, sees that the recommended target is below 130, and reaches for the prescription pad. A medication is added. A few months later, another medication is added to push the numbers lower. 6 months after that first appointment, the blood pressure reads 124/78. The doctor is pleased. The chart gets a positive note. Everyone in that room believes this is a good outcome. But here's what happens next. That same 78-year-old stands up in the middle of the night to use the bathroom. And in the few seconds it takes to go from lying down to standing upright, their blood pressure drops from 124/78 to 88/56. Their brain is not getting enough blood. The room tilts. They reach for the wall and miss. Now, we are not talking about blood pressure numbers anymore. We are talking about a fractured hip, emergency surgery, 3 weeks in a rehabilitation facility, a body that is suddenly less capable than it was before that fall. And for too many older adults, a fracture like this is the beginning of a cascade that ends in a permanent loss of independence. That scenario plays out thousands of times every single week across the country, and it is largely preventable if we understand one critical truth that the medical establishment has been slow to absorb. The blood pressure target that is right for a 50-year-old is not automatically right for a 75-year-old. These are biologically different bodies, and they need different targets. Before I tell you what the research says about the right numbers for your age, I need to explain why aging changes what blood pressure numbers actually mean, because this is the foundation of everything. And once you understand it, the numbers will make complete sense. 3 things change in the cardiovascular system as we get older, and all 3 of them matter enormously for blood pressure management. The first change is that arteries become stiffer. When you are young, your arteries are flexible, like a new rubber hose. They stretch slightly with each heartbeat, absorbing the pressure wave and releasing it smoothly. As you age, the walls of the arteries lose that flexibility. They become more rigid. Think of a rubber hose that has been sitting in the sun for 20 years. It does not bend or stretch the way it once did. When your heart pumps blood into stiff arteries, those arteries cannot absorb the pressure the way younger, more flexible arteries can. The pressure reading goes up. But here's the important part. Stiffer arteries also mean that your body needs slightly higher baseline pressure to push blood all the way to your brain and kidneys, especially when you are standing upright and blood has to work against gravity. A number that looks high on paper may actually be what is keeping your brain properly supplied. The second change is that the pressure sensors in your blood vessels slow down. Your body has tiny sensors called baroreceptors scattered throughout your blood vessels. Their job is to detect sudden changes in pressure and instantly signal the brain to compensate. When a young person stands up quickly, these sensors detect the brief pressure drop that happens as blood shifts to the lower body, and within milliseconds, the heart rate increases, blood vessels tighten slightly, and pressure stabilizes. The whole process happens so fast you never feel a thing. As you get older, these sensors become less sensitive. They respond more slowly. They take longer to send the signal and longer to produce the correction. So if your resting blood pressure is already low because of medication and your pressure sensors are slow to respond, the drop that happens when you stand up can go uncorrected for several seconds. Long enough to feel dizzy, long enough to lose your balance, long enough to fall. The third change is in how your body processes medication. Your kidneys and liver, which are responsible for clearing medications from your system, work less efficiently as you age. A dose of blood pressure medication that is perfectly appropriate for a 50-year-old can be too strong for a 75-year-old because the drug stays in the system longer and produces a stronger effect. The result is blood pressure that drops lower than intended, particularly at night and when standing, without any external sign that this is happening. Now let me tell you what the actual research found, because the specific numbers matter. The study I mentioned at the beginning, published in JAMA Internal Medicine, followed 15,342 adults over the age of 75 for an average of 5 years. These were not cherry-picked healthy people. They included older adults with diabetes, prior strokes, heart disease, and varying levels of frailty, real people with real medical histories. Researchers tracked their blood pressure averages and then recorded what happened to them over those 5 years. The results, organized by blood pressure group, looked like this. The group with systolic blood pressure below 120 had the worst outcomes of any group. They had a 28% higher risk of serious falls. They had higher rates of acute kidney injury, meaning their kidneys could not function properly without adequate pressure to drive blood through them. And their overall death rate was 14% higher than the best performing group. The group with systolic blood pressure between 130 and 140 had the best outcomes: lowest mortality, fewest falls, best kidney function, best cognitive performance. Not the lowest numbers, the moderate numbers. The group above 150 also had problems, as you would expect: more strokes, more cardiovascular events. But the critical finding, the one that should be changing how medicine is practiced for every person over 75, is that very low blood pressure was just as dangerous as very high blood pressure. The danger exists at both ends, and the target most doctors are still chasing sits right in the danger zone. Let me walk you through what this looks like in a real situation, because I think this will make the stakes feel very concrete. You are 76 years old. You go in for a routine checkup. Blood pressure reads 142/84. Your doctor looks at the guidelines and tells you that needs to come down, ideally to around 120. A medication is prescribed. 2 months later, your pressure is 128/78. Your doctor suggests adding a second medication to push it just a little lower. 2 months after that, your pressure is 122/76. Your doctor is very pleased. At first you feel fine, but gradually you start noticing something. When you get up from your armchair to answer the phone, there is a moment of lightheadedness. When you stand up from the dinner table, the room seems to tilt for a second. You mention this to your doctor, who tells you it is probably just your blood vessels adjusting more slowly with age. Try to stand up more gradually. But here's what is actually happening. Your blood pressure when you are sitting still in that doctor's office looks perfect at 122/76, but when you stand up, it drops to 95/60. Your brain is not receiving adequate blood flow every single time you move from sitting to standing. You are not feeling dramatically unwell. You are just feeling slightly off, slightly dizzy, a little unsteady, and you are writing it off as aging. Until one night you get up to use the bathroom, the pressure drops, you do not catch yourself in time, and everything changes. This pattern repeats itself thousands of times a day across the country. Doctors celebrating numbers that look good on paper. Patients experiencing symptoms that are being dismissed as normal aging. And the simple test that could identify the problem takes 3 minutes and costs nothing. Here is that test. I want you to do this at home tonight if you are over 70 and taking blood pressure medication. You need a home blood pressure monitor. You can buy one at any pharmacy for around $30. It is one of the most worthwhile purchases you can make for your health. Here is exactly what to do. Lie flat on your bed or sofa for 5 full minutes. Just rest quietly. After 5 minutes, take your blood pressure while you are still lying down. Write down both numbers. The top number is your systolic pressure. The bottom number is your diastolic. Now stand up and take your blood pressure again immediately. Do not wait. Take it within 30 seconds of standing. Write down those numbers too. Now compare the two readings. If your systolic pressure dropped by more than 20 points between lying down and standing, that is a red flag. If your diastolic pressure dropped by more than 10 points, that is also a red flag. Either of these results means you likely have orthostatic hypotension. This is the medical term for blood pressure that drops too far too fast when you stand up. Here is a specific example so you can see what this looks like with actual numbers. Lying down, your blood pressure is 125/78. That looks good by any standard. Now you stand up. Your blood pressure drops to 98/62. That is a systolic drop of 27 points. Your brain is receiving significantly reduced blood flow every single time you go from lying or sitting to standing, which happens dozens of times every day. Every time you get out of bed, every time you rise from a chair, every time you stand up from the toilet. You might not feel dramatically sick. You might just feel a little light in the head for a moment, a little slow to get your balance, a little unsteady for a second or two. That sensation is not nothing. That is your brain telling you it is not getting enough blood, and it is one of the strongest predictors of a serious fall. Your doctor should be doing this test at every visit if you are over 70 and on blood pressure medication. If they are not doing it, you can do it yourself and bring the results to your next appointment. That single piece of information could change the direction of your treatment completely. Now let me give you the actual numbers that the research supports as targets for different age groups. And I want to be clear about something important before I do. These are research-based guidelines, not absolute rules. Your personal target should always be worked out with your doctor based on your complete health picture. Every person is different. These numbers are meant to give you a framework for a smarter conversation, not to replace that conversation. For adults between 65 and 74, who are generally healthy and active with no major medical conditions, research supports a systolic target of around 130 to 140. This range provides meaningful protection against strokes and cardiovascular events while maintaining adequate blood flow to the organs. For adults between 75 and 84 who are reasonably healthy, the evidence supports a systolic range of 135 to 145. Notice that this is higher than the younger group. That is deliberate. It accounts for the arterial stiffness and slower pressure sensors we talked about earlier. The body needs more pressure to function well at this age than it did at 65. For adults over 85, or for anyone who is frail, regardless of their exact age, a systolic range of 140 to 150 may be most appropriate. At this stage of life, preventing falls and preserving quality of life and independence often needs to take priority over pushing blood pressure as low as possible. Now let me address the diastolic number, the bottom number, because it is equally important and often overlooked in these conversations. For older adults, the diastolic pressure should generally stay above 65, ideally between 70 and 85. The diastolic pressure represents the pressure in your arteries during the moment when your heart relaxes between beats. This is actually when blood flows into the heart muscle itself. When diastolic pressure drops too low, the heart muscle may not receive adequate blood flow. If your diastolic pressure is consistently below 60, that is something to bring to your doctor specifically, even if the systolic number looks acceptable. I want to show you something that I think illustrates the most important point of this entire conversation. Consider two people who are both 81 years old and both have a blood pressure reading of 158/88. The first person has mild heart failure, chronic kidney disease, and osteoarthritis. They live at home but manage some daily tasks with assistance. The second person is healthy and active. They play golf twice a week. They have no significant medical conditions. Same age, same blood pressure reading. Completely different situations. For the first person, starting aggressive medication to push blood pressure below 130 carries serious risks. Those medications could drop the pressure too much when standing, increasing fall risk significantly. For someone with osteoarthritis, a fall that leads to a fracture could mean the end of independent living. The medications could also worsen kidney function, because the kidneys of someone with chronic kidney disease depend on adequate blood pressure to filter properly. A more thoughtful approach might be lifestyle changes first, then, if medication is needed, a single low dose with very careful monitoring, and a target of perhaps 140 to 145, rather than an aggressive push toward 120. For the second person, the healthy, active 81-year-old, a reading of 158/88 might warrant some attention, but it does not necessarily require medication. Lifestyle changes, dietary adjustments, reduced sodium, regular activity might bring it down to 145/84 without any medication at all. And at that age, with that health profile, that number may be entirely acceptable. Same numbers on the monitor. Two completely different clinical conversations. The difference is in treating the person, not just the number on the screen. This is what I mean when I say the standard approach is failing older patients. When a doctor has 15 minutes with a patient and a computer screen showing a guideline that says below 130, it is very easy to prescribe without asking the deeper questions. How is this person functioning? What happens to their pressure when they stand up? Are they experiencing dizziness or falls? What is their frailty level? What matters most to their quality of life right now? Those questions take time. They require a relationship. And in a system where that time is rarely available, the number on the screen becomes the whole story. You can change that dynamic, not by being confrontational, but by being informed. By coming to your next appointment with specific questions, specific measurements from home, and a clear sense of what you want to understand. Here are 5 concrete steps I want you to take, starting today. The first step is to get a home blood pressure monitor if you do not already have one. Check your pressure at the same time each day, once in the morning and once in the evening, for 2 full weeks. Write down every reading. This gives you and your doctor a much more accurate picture of your true average blood pressure than 2 or 3 readings taken in an office environment where many people experience elevated pressure simply from the stress of the appointment. Home readings, taken in a relaxed, familiar environment at consistent times of day, are genuinely more useful for making treatment decisions. The second step is to do the lying to standing test I described, tonight if possible. Write down your results. If you find a drop of more than 20 points in the systolic number, or more than 10 points in the diastolic, bring those numbers to your doctor at your next appointment and ask specifically what they mean for your medication dose and your blood pressure target. The third step is to assess your symptoms honestly, not in the way that most people assess them, which is to assume anything unfamiliar is a normal part of aging. Be specific. Are you feeling dizzy when you stand up? How often? How long does it last? Are you more tired than you used to be in a way that is hard to explain? Is your thinking slower or less sharp than it was 6 months ago? These can all be signs that your blood pressure is being pushed too low, even if your sitting blood pressure looks fine by conventional standards. The fourth step is to book a specific appointment with your doctor to talk about your blood pressure target, not a general appointment where blood pressure gets mentioned briefly among many other topics. An appointment where you say at the beginning, "I want to spend time today talking specifically about what blood pressure target is right for me at my age, and whether my current medications are appropriate." Bring your 2-week home log. Bring your lying to standing results. Come prepared to have a real conversation, not to simply receive instructions. When you are in that appointment, ask your doctor these specific questions. What is the right blood pressure target for someone my age with my health history? Have you checked whether my pressure drops significantly when I stand up? Is my current dose appropriate for my age and how my body processes medication now? Are there any symptoms I should watch for that would tell me the pressure is too low? Could any of my current symptoms be related to my blood pressure being lower than my body needs? These are not challenging questions. They are exactly the questions that thoughtful, engaged patients ask, and a good doctor will welcome them. The fifth step is to speak up if you are experiencing any side effects from your blood pressure medications. This is important because many older adults silently accept symptoms they assume are just part of being on medication. They feel dizzy when they stand. They feel unusually tired. Their thinking feels a little foggy. They have balance problems that were not there a year ago. And they say nothing because they assume this is just the price of managing blood pressure. It does not have to be. Doses can often be adjusted. Medications can sometimes be changed or reduced. Targets can be reconsidered. But none of that can happen if you do not say something. Your symptoms are data. Bring them into the conversation. I want to address one more question that I know many people have when they hear this information. If this research exists, why has my doctor not mentioned it? Why are the guidelines still pointing to 120/80? The honest answer is that medicine changes slowly. The major studies that established 120/80 as the target were conducted primarily in middle-aged adults. When those results were published, the guidelines were written to apply broadly, without enough distinction between age groups. The assumption was that what protects a 50-year-old must protect a 75-year-old equally. Over the past decade, researchers have been looking specifically at older populations, and the findings have been consistent. One size does not fit all. But it takes years for new research to move through the process of being reviewed, accepted, incorporated into official guidelines, and then taught to practicing physicians. And it takes even longer for those guidelines to actually change what happens in exam rooms. Many doctors practicing today were trained on the old targets and have not had the opportunity to deeply engage with the newer research. That is not a failure of character. It is a feature of how large and slow-moving healthcare systems work. But it means that informed patients who understand the research and can speak to it specifically, have a real role to play in their own care. You are now one of those patients. You know that the blood pressure target for a 75-year-old should not be the same as for a 50-year-old. You know that systolic pressure between 130 and 140 is associated with the best survival outcomes in older adults. You know that dropping below 120 increases fall risk, kidney injury risk, and overall mortality. You know that the drop in pressure when you stand up is often more dangerous than a moderately elevated sitting reading. You know how to test for that drop at home. And you know the questions to ask at your next appointment. That knowledge is not a small thing. It is the difference between being a passive recipient of medical decisions and being an active, informed participant in your own health. One more thing before I finish. If someone you care about is over 70 and on blood pressure medication, please share this with them. A parent who has had a recent fall and nobody has connected it to their blood pressure treatment. A friend who mentions feeling dizzy when they stand and has been told that is just aging. A partner whose doctor recently added a second medication to push their numbers lower. The information that prevents a serious fall or a lost independence is only valuable if it reaches the right person before the fall happens. If this gave you something useful today, share it with one specific person, not a general share. Think of a face, a person whose situation this applies to, and send it to them directly. I'm Dr. William Madison. Your health is worth understanding completely, not just managing from a distance. Take care of yourself, take care of the people around you, and I will see you in the next video.